All right, we have a wonderful case here to look at. It is replacing tooth number 9. So the first question I always ask myself is what kind of guide can we use here and do we intend to use here? And the first thing that comes to my mind is that an OptiGuide is a possibility. So to do an OptiGuide, we would like to have a pretty large, most of the arch on the CEREC scan. And as we can see here, we do have that. Now, if I were to be nitpicky about this, I would say I would love to go back to molars back here. And there's a couple of reasons. One is then I can use a bite block very safely to help hold the guide in. And two, it just, again, with the OptiGuide, since we don't have that snap fit with the OptiGuide due to the undercuts, I would like to have a very good stable base. Again, what you have will work, but again, we're just going based on ideal. The next thing I look at when dealing with anterior teeth is gingival margin, our CEREC design in this particular case, and how that affects it. So it is very important to have a very good CEREC design. And what I would like to do is just quickly show one thing here on the CEREC design. I do notice that there is a difference in the thickness between number 8 and number 9. Now, again, this may play a role, it may not play a role, but my goal when we design these is to get as close to possible as ideal, because a millimeter in thickness can make a difference in the placement, again, when we're nitpicking things. And to me, the goal is to have ideal placement, ideal planning. So I would like to see, in this particular case, see the restoration planned out a little bit better. So just to kind of give us an idea here, I would like to maybe draw out where we could, retrospectively, where we could have drawn our margin. So maybe in the future we could draw our lingual margin probably something like that. And it's always good to look at your neighboring tooth. To be able to see. Now again, I'm being particular, but it is this particularness that gives us the great results, which is what we all want. So in an ideal world, we'd like to see this come out just like so. Now if we take the same thing and look at it from the facial, we look pretty good here, okay? But again, just to be able to show us, what I like to do is just visually take a look at the adjacent teeth, just like so. And again, I think we could see a little bit more filled in right here and a little bit more filled in right there to give us a little bit better proposal. But again, what we have is very good. I'm not saying that what we have is bad. So let's go ahead and take a look at our implant design. To get us started, I would like to go ahead and duplicate our plan under my name. That way I can have the original plan there and I can have my plan there and I can make changes as I see fit. So what I want to go ahead and start with here is let's take a look at what we're doing here. Now, we're following the rules, the 3x2 rule, which is that our implant should be 3 millimeters apical to the intended gingival margin and 2 millimeters palatal to the bone. So this will give us the ideal scenario. Now, in looking at your line, we have a 3.5 millimeter line, and then we look at our implant and we can see that our implant is not quite to the line that we drew. So we could go ahead and take the implant to about right there. Now, what this also did is we can see that we had thin bone right here, but what we can see here is now we have the implant about the level that we want to be able to support this tissue. And what this is going to allow us to do here is now build a nice emergence profile. Now again, that is important, especially with anterior teeth. What we don't want to have happen is have the implant where we had it, and then building that emergence profile becomes a bit more abrupt, and we don't have the room necessary to develop that tissue. But in this particular case, what it does mean is that we may have to reduce a little bit of bone, or, you know, just kind of be a little prepared for what that's going to mean. So to do this, let's go ahead and outline our bone, which is right here. Let's outline what appears to be our tissue, and that looks to be right here. Okay, and this gives you an idea of what we're working with and everything so forth. So all of this bone right here is extraneous bone. Now the good news is when you do your osteotomy, all of this bone right here is going to be lost, and I personally wouldn't mess with this bone right here. I think we'll be able to build it out, we'll preserve it. I don't want to remove it. I believe it'll go away on its own. So just kind of be aware mentally of what we're looking at here. Now let's go to some areas that I have concerns. So our first principle is that ideally, when we're planning anterior implants, we want the implant access, or the long axis of the implant, to come through the incisal edge or slightly palatal, or through the cingulum. So the first thing I notice here is that our implant is coming right through the buccal. So I know right away that maybe this can only be the way it can be done, but I also know that right away I'm going to need a custom abutment. But what I really become concerned about here is where it's emerging right here. And because of this emergence, I'm very concerned that we're not going to be able to hold our tissue, and we're going to have a great risk of causing some recession. And depending on the smile line, I get worried about that. But more importantly, even if the smile line doesn't show it, I just don't want that recession, especially when it seems to be that we have enough bone. The next thing I look at is mesiodistally. If we were to draw a couple of lines from this implant right here to that to there, we can clearly see that this line is longer. So this implant is placed a little bit to the mesial. So ideally, if we use our technique of just outlining right here, we could probably say that this implant should be about right there. Okay, and then technically we'll want it to go that way. So maybe we want the implant head to be coming out about right there. So let's go ahead and go through our checklist. Buccolingually, we're centered, we're very nice, we have adequate bone. Looks like this was a tooth that was taken out and grafted. Probably the reason we have so much good bone here. Mesiodistally, it becomes hard to tell, but one of the things I'm concerned about here is it looks like we may be quite close to the incisive canal. Okay, so this will also go along with the fact that we're a little too mesial. So by moving the implant distal, one, we will get it centered, and two, we'll get away from this incisive canal right there, or the potential incisive canal, I should say. So let's go ahead and start planning. So the first thing I'm going to do is I'm going to drop my implant to about the depth that I would like it to be at. Then number two, I'm going to get this from coming out of the buccal. I'm going to get it coming from the incisal edge, something like so. I do think that's enough bone, but I would like to be on the safer side and have more than enough bone, so I'd like to move it right there. And then the next thing I want to do is get this moved over and through the center. Now I'm too close to this root right here. So what I'm going to do is gently go like so. And now what I want to do is notice right here how these roots, let me draw in here for us, just to better show us what it is I'm looking at. If we look, and again, I'm a big fan of just mental visualization. If we look right here. So all these roots are kind of pointed that way. Kind of pointed that way. So what I would like to see in an ideal world is then my implant should maybe be pointed that way as well. And I've exaggerated here, but to kind of give an idea of why I'm doing what I'm doing here. So now I'm going to go ahead and tilt my implant like so. And if you notice, when I do that, look what happens to the roots. They become straight up and down. And that's kind of where we'd like to see everything. Okay, now we get a little bit more centered, come over a little bit, and now we can start seeing that things are starting to look a little bit better for us. Okay, so you know, our implant is now centered in the tooth. It's coming through the incisal edge, or just parallel to the incisal edge. We've got plenty of room on the buccal of the implant, which is my most concern. Plenty of room on the lingual. We're avoiding vital structures up here. Again, the bigger question is going to be this incisive canal, and we'll take a closer look at that here in a second. And it may be that we need to go to a slightly smaller, narrow diameter implant. And technically, we can go to an even longer implant if we choose, but there's definitely no need. In fact, the literature is pretty clear that 10, 11 and a half, 13, more than 10, adequate, 11 and a half, pretty good, 13 is more than adequate in these particular situations. So I'm going to go ahead and tilt the implant a little bit more, get it centered nicely. I really do like this. Okay, and then the last thing I want to look at is my implant depth. Again, typically would talk to go to bone level, but we see we have so little tissue here. We're not going to have, assuming that this is the correct gingival margin placement, which it looks to be, we want to be a good 3 millimeters below. So we need to drop this implant to say about right there. Now we have more ideal implant placement. What I also notice here is we have plenty of bone. We're going to have good stability. We're going to be able to immediately load this with the provisional that's taken totally out of occlusion. You know, I see a good implant here. So now the next step is to go through our 360, and this is where we're going to look for vital structures, look for bone, look for tooth, and we can see that we're good here. Maybe this root curves a little bit, but since we're using a tapered implant, we don't have to worry so much about that. And then there we can see our palate. I think we're good here. I don't see any area of the incisive canal. Maybe right there. And we have plenty of distance from there. Very confident. One of the last checks, which we didn't check here, I apologize, is our sleeve system. So we'll go over to the sleeve, check our sleeve, go to Nobel Guide, put that in there. And if you know what I'm looking for here is, one, is my sleeve going to be hitting the adjacent teeth? That's not. And two, is my sleeve outside of the tissue, so I can do flapless surgery, and I can. So again, depending on the amount of keratinized tissue in this case, we have the ability to do flapless surgery. And this is a relatively straightforward case. So what I would like to do is take a look at this here. Let's look at our plan number 1, what was sent to us, and we can see where the implant is coming out of the tooth, where we have good bone around the implant. But then if we go to the plan that I just created here, we can see again, the implant is now better centered. It's not coming through outside of the buccal of the tooth. And we still have plenty of good bone all the way around, and we've not given any compromises. So this is a more ideal position for this particular case. So I thank you for sending the case. It is always very nice to have these. If you have any additional questions, please don't hesitate to contact me.